Hello, everybody, and welcome to my YouTube channel. This is Resi Prep 360. Today, as part of the Road to Match Day series, I am going to be going over effective patient case presentation and how to organize them. I am hoping that this is a great resource for not just folks applying for residency presently and actively interviewing, where you have to put together an effective patient case presentation, but I'm hoping that residents, future residents, and as you guys progress through your professional careers, this can be a resource that exists out there to help guide future students and current residents on how to put together a thorough and effective patient case presentation. If it's your first time here, welcome to my channel. My name is Sale Traore Uwalaka. I am a pharmacist, a residency trained pharmacist. I am also the founder of Resi Prep 360 that introduces and works on the Road to Match Day as a series every year where I help prepare highly competitive residency candidates for a successful match at phase 1. And so without further ado, we're going to go ahead and jump right into the patient case presentation. As I felt, there are a lot of different things today to go over in detail because I want to make sure you guys are always nailing these. I have two major objectives today, recognizing the difference between topic discussions and case presentation, because this also continues to be a major pain point for student pharmacists and new practitioners, understanding the difference, how to structure a topic discussion and a patient case presentation as a pharmacist, creating a topic discussion and patient case presentation and what goes into that. And today the focus will be on case presentation. By definition, patient case presentations and the reason why through your academic career and your learning arc, this is going to be such a common and reoccurring thing that you have to do. And the reason why it's important that you know how to do them and do them well, it's because they allow your preceptor to really make sure that you have good command over a specific disease state through real world application of guidelines and real world application of literature, and what the information we have presently available to us guides and dictates to us about how we should be managing certain patients, no matter how simple or complicated the disease state may be. Oftentimes, these are patients that you have encountered. That's the hope. The hope is that there are things about this patient case and insight that you're going to possess because this is a patient that you've met in real life. Your connection to the case you present will be a little different if you were just given a piece of paper and told to read and then present on how you would manage that patient, as opposed to somebody you've actually met and that you've had a conversation with and gotten a chance to know them and putting a plan together for that. They can be something you pick yourself, or maybe your preceptor themselves decided that they were going to assign one to you. This can come to you by all means. And so we were going to talk a little bit about structure because this is very important. You have to put your case together as if your audience have no clue who this patient is. Even if this is a patient that they have encountered before and maybe loosely familiar or even very familiar with, you've got to start from the beginning. And that is the chief complaint. The chief complaint will usually be in quotation mark, but this is what brought the patient to the ED. I'm so short of breath. My hair is falling out. My stomach hurts. I'm so nauseous. I haven't been able to keep anything down. You want to make sure you are able to say clearly what forced the patient to seek medical help, and when they got to help, what were the patient's exact words when they got here as far as what their complaint is. The history of present illness, or HPI, is usually next because this gives us a few key pieces of information. It can give you information about how long the patient has been dealing with this. It can give you information about what they have tried that has made it better or worse. They can tell you things like, my shortness of breath is worse when I lay flat, and this has been going on for the last 3 days. But in the last 24 hours, I haven't even been able to get upstairs at the top of the stairs. They'll give you their past medical history here. They'll tell you I have a history of diabetes, hypertension, chronic kidney disease. But the history of the present illness is a better grasp and understanding, and usually the patient is able to share this information with you. They may say things like, maybe I also, my head was hurting really, really bad, and I took my blood pressure at home, and the machine told me that my blood pressure is like 200 over 170. So I called my doctor. He told me to come to the emergency room. Objective information. This is going to be a great part of your patient case. But when you're doing a case that's only about 30 minutes or maybe 1 hour, you will have to be selective about what information you put out. The social history doesn't tend to be as extensive as the family history, allergy history, and the list of home medications prior to admission. These you probably will have to report in full. You will have to say all of what the patient's history is, and isolate family history that is specific and relevant to our chief complaint. And or so, for example, a patient who comes in and there's a suspicion of cardiac or a suspicion of hypertensive urgency or emergency, that patient's family history of any first degree relative, more often more relevant than others, but their parents dying of sudden cardiac events before the age of 65 or the age of 55. These are relevant pieces of information we are going to care about knowing, because it's all part of the patient's risk assessment. For laboratory values, and this is in particular for residency interviews, you will not be able to report on every single lab drawn on the patient. Focus on abnormal labs here and laboratory values that help you with your differential assessment of ruling certain things in and being able to positively rule other things out. Review of system is the same thing. If the review of system is that everything was within normal limit and nothing noticeable to report, put that there. But if they have things where they are describing lesions on the patient's skin or anything abnormal, that's what you want to draw attention to. Imaging and diagnostic result is very important, because imaging and diagnostic results, when you place those side by side with laboratory value, this is how we are usually able to produce a confirmatory diagnosis to say with absolute certainty, or there's high probability that there is a DVT or a PE, with high probability that the patient has heart failure based on ejection fraction from echo. You want to look at imaging always when you're working your patient up and putting your case together, because the imaging results can be a great supporting document to confirm the diagnosis and even help inform what pharmaceutical care plan may be more appropriate. Once you have all these information, then you need to outline the patient's course of hospitalization or the chronic disease's progression history, right? Somebody who is in the hospital, and this case is about heart failure, and the patient presented acutely decompensated. They got certain things in the emergency room, and they got admitted. Certain medications were switched around. Hospital stay day 1, 2, 3, 4, and 5. You may want to take your audience through a journey of from the time the patient came into our care and they hit the door until where we are now. Here are the significant medical events that have happened during the course of that time since the patient has been here with us. These, I think, are usually beautifully represented in the form of infographics, in the form of timeline infographics and things like that. You want to give your audience a break and use a really good balance between images, graphs, infographics, but also words on the slide. You want to have a nice balance of that. So the course of hospitalization or progression of the case is very important as something that you want to make sure that your audience can have. Next, a problem list is going to emerge as a result of the imaging results, the hospitalization course, and everything. This is where you are going to clearly outline what the patient's acute problems are. And this, people think that this is dramatic or whatever, but to understand the patient's problem list and making sure that you are listing them correctly in descending order, just ask yourself, which one of these puts the patient's life at risk the most? That becomes problem number 1. Usually isolating problem number 1 and number 2 Three, four, and five, if we have them, they tend to just kind of fall in place really, really beautifully with very little effort. But I think a lot of students struggle with isolating the acute problem, problem number one, more than anything else. And then the rest of them tend to fall into place. Now, it's time to do a review of the disease state, right? The disease state review is very important because you want to demonstrate that you have a good understanding of structure and function. The case will likely focus on an organ system or an organ function. I do not know how anybody is able to embark on appropriate design of a pharmaceutical care plan if you don't have good understanding of structure and function and the pathophysiology. And to understand pathophysiology, you need to really understand under normal circumstances, what do we expect this organ system to do? Because that organ system, once you have good command and a good understanding of what the organ system does under normal circumstances, you can pretty much understand that, like, okay, well, if that organ system is messed with, is disrupted, is hindered in any way, this my hypothesis comes into focus really quickly as to what are some of the things I can expect to be off, whether those are labs, whether those are symptoms, whether those are signs, actual signs and symptoms. You have less of a job having to memorize, but you are functioning from a place of understanding. Disease course and prognosis is definitely important. And then, what are the evidence-based management strategies? That takes us into clear isolation of the clinical challenge. You have got to state for your audience what your problem is that you are trying to solve, because this is where literature review will come in. So, for example, the audience has to know, what is the guideline recommended management for uncontrolled blood sugars greater than 600? What is first line treatment for CHF? Or perhaps, what are the 4 pillars for HFrEF management? What is the guideline recommended treatment for newly diagnosed HIV positive cisgender male? But the audience has got to know why the evidence you picked to review to make your clinical decision. How did you choose that that's the evidence you're going to need to review? And what did you learn from the evidence that you reviewed? You have to outline that for the audience. Review of disease states, again, has got to have one of the biggest things that many of you forget: goals of therapy. You have to include in the disease review process the goals of therapy. Your audience has to know, what are the goals? What did the guidelines say here is the goal? Decrease mortality, symptom management, reduction in hospitalization. You cannot assume that your audience will know that that's why you're making the choices you're making. You've got to state that explicitly. For the assessment and plan component, it's really, you want to assess each problem individually, and you want to restate the goals of therapy for the disease state you're focusing on. Where you are getting the goals of therapy has to be cited. You cannot assume. Describe the objective and subjective information that you are leveraging, that you used, that supports the diagnosis. So if we are saying that someone has heart failure with reduced ejection fraction, you need to quantify the ejection fraction for them. If we are saying that somebody has a hypertensive urgency, you've got to be able to isolate what the patient's presenting blood pressure was and why that is an urgency versus an emergency, right? And classify the management of the disease. Are they goaled, controlled, uncontrolled? It has to be explicitly stated. And what is currently being done for the disease state? And this is usually where the hospitalization course can be really important, because you have to describe all of the medication-related problems that you find here. You are a pharmacist. Here is one of the most important steps of your patient case presentation. A pharmacology review is paramount. Each medication, a pharmacology summary of what they are being used for. And for your case and the disease state that we are talking about, it's imperative that you describe all of the medication-related therapy problem you find with this patient's issues. Is it doses too low? Is it ineffective medication? Is it that there's a synergistic approach that's not being leveraged fully? Dose needs to be optimized and titrated up, so on and so forth. But it's very important that you do this part. Otherwise, you're going to face a lot of questions during question and answer component of your presentation, because your audience, if you're presenting to a group of pharmacists, they're going to care about how you arrived at this plan. So if the assessment is too shabby or the assessment is not thorough, yeah, you're going to spend a lot of time explaining, well, why? Well, how? Well, what? They'll have a lot of questions about that. The plan has got to be evidence based. It has to be right from the guidelines. Anytime your plan deviates from what is recommended in the guideline, you've got to speak to that, because I assure you that there's someone in the audience who wants to know, why is it that we're not using guideline recommended therapy, right? And so outline the pharmacologic and non-pharmacologic therapies for your rationale and the plan. This is important. I think many people, when they present their patient case, are so focused on pharmacologic management that we think about, that nobody really thinks about non-pharmacologic. And then you find yourself stumped, because they will ask you about non-pharmacologic. They will ask you about primary prevention, so vaccines, smoking cessation, education about obesity. They'll ask you about all these different things, right? There are very few chronic diseases today, especially if there are chronic diseases that put the patient at risk for certain things, where we don't have clear recommendation for vaccines that those patients should be on. You should be looking at that, to look at what vaccination, and is the patient up to date on all of their vaccinations, right? Monitoring and follow up is one of those other areas that many students and residents forget to include in their patient case plans, right? What do you monitor for? There are two key things we always monitor for whenever we are dealing with patients' care plan. We monitor for the safety of the plan enacted, and then we monitor for the efficacy of the plan enacted. You need to be able to clearly tell your audience you're going to monitor, let's say if it's an antibiotic, right? We have to monitor for safety. Some of those safety parameters can just be renal function, right? But if it's for efficacy, we want to know that the antibiotic selected is actually working. Patient's fever curve, their white count, right? You have to clearly say what you are going to monitor for efficacy and what you are going to monitor for safety. This is one of those things that a lot of people leave out. So you including it in your case is going to be a huge bonus. Or there's specialists that you want the patients to follow up with. You've got to say when. Same for you. When do you check for efficacy? You start a patient on a new blood pressure medicine. How long after initiating the blood pressure medication do you want to see the patient back in your clinic? You have to put time to what you are monitoring and when you want to see that patient for those monitoring parameters. I have this included here because I really wanted to pull the assessment out by itself for you all to see it, other than having it sitting there with the plan, because it's such an important part. This is the part that goes right to the heart of the case about whether or not you have good command and a good understanding of disease state, disease process, and disease management. Spending time on making sure that your assessment is clear, it's concise, and it is thorough is how you are going to wow your audience when you're putting a patient case presentation together. Your plan, they know that you can look in the guidelines and pull a plan out. But the assessment component goes right to the case of your ability to problem solve and think critically, and your ability to kind of globally get all of these different information and connect them to direct patient care in order to make a decision. That's why the assessment component of your case is such an important piece, and you making sure that you really take the time to work through each of these bullet points and you're clearly able to outline it for them. This is not required, but I think it's great practice to summarize the patient case and pick out three things. Three things. I think three is more than enough, especially because majority of your clinical cases, presentations are going to be half an hour at the most. Unless you're a resident, you may find yourself being asked to present for about 45 minutes and 15 minutes for question. But think about takeaways for your audience. What are 2 to 3 things at the most you want your audience to walk away with feeling like, yeah, if I see this case again, I know exactly where to start. This is where I would start. I would do bam, 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 bam. If you feel like you can do that effectively, not only does it convey to the audience that you did the work and understood the work you did, but the audience also walks away with more than just, yeah, I went to a talk about plaque psoriasis. That is your patient case presentation. There's something else that I just think goes without saying, but I'm going to say it. Make sure that you include your references at the end of your case presentation. It's imperative because most of what you're doing here is taking other information and putting it into a context of your patient care to present it. But I think it's extremely important that you get in the habit of citing all of your work. These are some simple presentation tips you have to practice. I don't think that it's smart, it's wise for you to put your presentation together and have so much confidence in your ability to present that you do not practice. I strongly recommend that you practice. It always practice, right? Make sure that the presentation slide deck flows and the ideas connect. Jumping all over the place can be very confusing for your audience. You must proofread diligently. Typos and all these different things, they are embarrassing to discover in real time, and you want to make sure you catch them. Do not guess. When you get to question and answer session, do not guess. I will look that up and get back to you will never be the wrong answer. But I always tell people, for a 30-minute presentation, you shouldn't have more than 2. You should not have more than 2. I will look it up and get back to you. And pretty much, I just think that if you think about a 70% rule for presentation, it would serve you well. If you are asked 5 questions, at least 3 questions you should be able to answer in great detail to demonstrate good understanding of the concept. If you have to look anything up, you need to do so as soon as possible. Everybody you have to get back to, they cannot wait till next week for you to get back to them. It is the professional thing to do to work on those responses immediately and get back to everyone you said you would get back to. Respecting the time you have for a presentation is imperative because for me, it doesn't matter how excellent your presentation is, but if you were given 30 minutes and you presented for 45 minutes, immediately my evaluation of your presentation is going to be poor because part of the assignment is following instruction. And if a key instruction is that you only have 10 minutes, you need to figure out a way to present that case in 10 minutes where you're hitting all of the key points and staying within the allotted time of 10 minutes. This is how you shine. This is how you shine. Demonstrate that you can think critically, right? There are some things that you should have good command of, minimum. The disease state, its pathophysiology, leveraging clinical evidence to make a decision, being able to say, here's what the guideline recommendations are. Now, when I look at our patient and I look at the patient's age, their renal function, their liver function, this dose is safe and should be effective based on my understanding. That is how you shine. Some things you are expected to have mastery of. Identification and solving of the medication-related problem. They are expecting that. Your ability to interpret all of the labs and connecting the labs and the imaging results to the primary diagnosis. They are expecting you to be able to do that. They are expecting you to be able to look at patient-specific factors that can affect care plan. This is so important. Social determinants of health. They are nowhere in the case, but there are going to be things in the presentation that you learn about the patient that are going to have huge impact on the choices you make for them. For example, if the patient is homeless, if the patient has poor health literacy, if the patient does not speak English or their English proficiency is poor, if the patient has dexterity issues, right? If the patient is legally blind or just fully blind, if the patient is deaf, there are things about your patient that have nothing to do with health but have big, big, big consequences on the outcome of the care you decide to provide. A patient who is blind cannot read a pill bottle. you have to think creatively around how you're going to package that patient's medications for them. A patient who has dexterity issues isn't going to be able to dial an insulin pen. You have to think creatively about how to get insulin delivered to that patient. But I think the social determinants of health is one of those things that tend to get left out when folks present. And it's very, very important that we are thinking about them as we design our plan. I cannot tell you thank you enough for watching to this point. I hope this helps you. Leave me a comment below for clarification, for questions you may have, or just tell me that this video, you find it very, very helpful and that I should put out more things. Maybe actually give you a patient case presentation that I put together for you so you can see a real example of what that would look like. This channel is designed with you in mind. This channel is designed thinking about the things that you find challenging as you go through API year, on your way to becoming a resident, and surviving residency year. If there are any topics you would like me to talk about, please don't hesitate to drop it in the comment or message me. The notification button allows you to see when I post a video immediately. Please subscribe to this channel. Please comment. Let your friends know why they should also subscribe to this channel and why this is the only channel that is committed and dedicated to providing you with all of the resources you need to making sure you match at phase 1. Until next time, everybody, bye.